now I'm introduce the next speaker. Next speaker is Professor Shamia. She's working in the Institute of Hematology, Peking University People's Hospital. He's very famous in China and in the CL areas. So do a lot of things. So now please, Professor Yang.
Very kind introduction, and now I am not a speaker. I will introduce. It's my great pleasure to introduce Professor Peter Hillman. He's our old friend, and he is the professor of experimental hematology, University of Leeds, and we were very familiar when we were in Edinburgh, because at that time he is the chairman of the IWCL 2019, and he's both expertise of PNH and chronic lymphocytic leukemia. He have coordinated many phase 2 and phase 3 trials of the novel agents or combinations. The very famous is the TAP Clarity study. So please, Professor Peter Hillman.
Hello, I'm Peter Hillman, Professor of Experimental Hematology at the University of Leeds, and I'm going to talk today about the optimal choice of CLL treatment in 2021. This is Leeds. These are my disclosures, mainly around clinical trials for CLL that we've done over the last years. So we first of all, when deciding on therapy for CLL, have to decide on what our aim of treatment is. And this can range from improving the patient's symptoms to disease control, protracted treatment-free period, and hopefully with some patients moving towards a prolonged survival and cure. And what influences the choice of treatment? Well, first of all, the patient's age and comorbidity. As we've heard, this is a disease predominantly of the elderly with a median age, so in our community, of 72 at the age of diagnosis. So what's possible? The patient choice, and increasingly, of course, patients will be involved in the decision as to what therapy they want to have, and including the patient's family. And then, of course, what treatments are available or appropriate. So what previous therapy the patient may have had, the type of CLL, whether it's mutated or unmutated, we'll talk about, and what therapy is available, particularly in the country the patient lives in, for example. I think we always have to think in CLL what our future strategy is, because we have many different treatments, and we don't want we want to use them in the most appropriate way and what's possible. So we really have moved in the last few years away from chemoimmunotherapy, and I'll show you the evidence for that. But we can think now of the decision regarding treatment between a fixed duration therapy aiming at a deep remission, or a continuous therapy to control the disease. And on the left, I've shown you the currently used continuous therapies, which are only B-cell receptor inhibitors. BTK inhibitors predominate. The ones that are currently approved are the irreversible covalently linked inhibitors. So obviously ibrutinib has been the first one, acalabrutinib approved in some markets, and zanubrutinib following through. And now the development, I'll show you one slide later on, of the reversible inhibitors to try and overcome resistance. The PI3 kinase inhibitors I'm not going to talk about in any great detail, as these are largely being superseded by the BTK inhibitors. And when we first developed venetoclax, the BCL2 inhibitor, venetoclax monotherapy was used as a continuous treatment until disease progression. On the right of the slide, you can see fixed duration therapy. So obviously chemoimmunotherapy, which has been the gold standard for many years, alkylating agents with antibodies or pure analog-based therapies, particularly FCR, are the archetypal fixed duration treatment. But now we're starting to look at combinations of venetoclax with antibodies, or with BTK inhibitors, or even all three together. So first of all, in the previously untreated patient requiring therapy, we can consider a variety of factors which might influence treatment, whether they're eligible for FCR or not. the biological features of the disease, i.e. whether mutated or p53 disrupted. So if you look at the data, I'll show you a number of Kaplan-Meier curves shown in this way, with the progression-free survival on the left and the overall survival on the right. The trial that really in frontline defined ibrutinib and is the longest follow-up of the randomized trial is the Resonate-2. This is a randomized trial in elderly patients comparing ibrutinib monotherapy until disease progression compared to chlorambucil. And we're now in 6 years or more follow-up, and you can see that there's a significant advantage in favour of ibrutinib with a hazard ratio of 0.146 in terms of PFS. And also, despite a pre-planned crossover to ibrutinib, if you progress on chlorambucil, a significant improvement in overall survival, demonstrating that you really should use your most effective therapies in frontline, the hazard ratio of 0.45. We have had recently the next generation or slightly more targeted BTK inhibitor, acalabrutinib, in the Elevate treatment-naive trial, or TN trial, presented by Jeff Sharman and recently published, showing a significant advantage for acalabrutinib with or without obinutuzumab over chlorambucil obinutuzumab, as you can see here, with the hazard ratio significantly in favour of both the acalabrutinib arms of 0.1 or 0.2. On the right, you can see as yet there's no overall survival advantage in favour of the BTK inhibitor, but this is a more recent trial where patients have more options in terms of crossover, and so we need to follow this trial for longer. The median follow-up's only just over 2 years. What about more compared to more effective chemotherapies? We have 2 major trials thus far comparing ibrutinib with or without rituximab with bendamustine rituximab. This is the Alliance trial, showing significant advantage again in favour of the ibrutinib arms over the bendamustine rituximab arm, hazard ratio of about just under 0.4, and no difference with the addition of rituximab. Again, this is an elderly group of patients, and there's no thus far advantage in overall survival. The trial that probably changed the treatment of patients was the ECOG 1912. Shown here, this is a randomized trial, 2-to-1, ibrutinib rituximab versus FCR, presented by Tate Shanafelt, published the year before last, showing a significant advantage against the gold standard FCR in a young patient group of patients. These were patients in their late 50s, showing a hazard ratio of 0.35 in favour of ibrutinib rituximab in terms of PFS. But what really made a difference and was of note was the overall survival advantage in favour of ibrutinib, which again was significant. As you can see, p-value of less than 0.001, and a hazard ratio of 0.34. So continuous therapy with BTK inhibitors is clearly effective. What about in the subgroups? I mentioned the VH unmutated versus mutated. We've heard about this earlier on in the meeting. And you can see the 2 large trials, the ECOG 19 on the 12 on the left, and ibrutinib Resonate-2 on the right, showing the mutational status. It's clearly in unmutated patients there's a significant advantage shown on the ECOG study. The mutated patients, there's less patients in that randomization, and it's not really powered to show a difference. And we're waiting for the large trials, which I'll briefly mention later on, to be reported. And on the right, you can see that with the chemotherapy arm, the unmutated patients are doing worse, but this disadvantage is seemed to be lost with ibrutinib. So very good evidence that in the VH unmutated patients, a BTK inhibitor, certainly ibrutinib, shows an advantage. If we look at T53 mutated or P53 disrupted CLL, which is about 10% of patients requiring therapy, we have less data in frontline with ibrutinib. This is the work of Adrian Vishna's group, showing a very impressive progression-free and overall survival in a non-randomized trial, only 34 patients, but follow-up out to beyond 5 years, which is far better than with other non-chemotherapy approaches prior to ibrutinib. And then there was a analysis at last year's ASH combining 4 clinical studies and the 17p deleted patients or P53 mutated patients in these trials, again showing very good progression-free and overall survival, with a 4-year PFS of just under 80% and overall survival 88%. And this was backed up by real-world data from America, presented by I think Antimato's group showing a significant, a similar outcome in terms of 17p deleted patients. So it would appear certainly this is the optimal treatment for p53 disrupted CLL. And just to mention the mutations, we don't see resistance mutations very frequently in frontline, shown in yellow, but we do see them occurring with ibrutinib over time in the relapse refractory setting after failing chemotherapy, and this may make us think of other approaches to treat these patients with combinations, which I'll mention at the end of my presentation. So what about the fixed? So that's continuous therapy until disease progression. What about the fixed duration therapy in frontline? Well, the only trial we have at the moment in the randomized setting in frontline is venetoclax obinutuzumab in the German CL14 trial, and this has been reported. This is the update from last year's ASH by Dr. Al-Sawaf, showing a significant advantage of venetoclax obinutuzumab over coramitug obinutuzumab. This is after stopping therapy at 12 months, but as yet no difference in overall survival. But again, this is a trial done in more recent times when there's availability of other targeted therapies. If we look in that trial at mutational status, you can see in the dark curves are the VEN-O, the solid line is the unmutated, and you can see, unlike the ibrutinib, relatively early on after stopping therapy for 12 months, we're seeing a separation in unmutated from mutated. There's no in both types of CLL, there's an advantage in terms of the targeted treatment. Of course, in this trial, retreatment will be an option, and we really need data on retreatment before we can fully assess the impact of VEN-O on the unmutated setting. If you look at MRD and the depth of remission at the end of therapy in these fixed duration treatments is important, and you can see regardless of the therapy, if one achieves an MRD negative peripheral blood at 12 months, and the dotted line, they do better than patients who are MRD positive. And this is, we'll talk a little bit about the tailoring therapy by MRD response a little bit later on. And if you look at the 17p deletion in the solid line, you can see the 17p for VEN-O, and these patients are relapsing even through venetoclax obinutuzumab, with about just over half the patients still in remission just beyond 3 years. So maybe this isn't the best approach compared to the continuous BTK curves I showed you before. So what about relapse refractory? This obviously will change as patients are now on chemotherapy, not on chemotherapy in frontline, but the RESONATE, which is the longest randomized trial, showed a significant advantage in favor of ibrutinib over ofatumumab in patients who have 3 prior lines of therapy. So continuous therapy is effective, although not as effective as in the frontline, as I mentioned earlier. Whereas we've got data now from the ASCEND trial, which is acala versus idela rituximab predominantly, or benda rituximab, again showing a significant advantage for acalabrutinib over idela or bendamustine rituximab, but no difference in overall survival. And so in the relapse setting, BTK inhibition is effective. What about and this is just to mention, we have to consider side effects over time, particularly cardiac and diarrhea, but I don't have time to talk a great deal about this. If you look at fixed duration, the study which has defined fixed duration therapy in relapsed diseases, the Marana study, with 2 years of venetoclax rituximab as a fixed duration, 6 months of rituximab, compared to bendamustine rituximab. This is the latest follow-up from last year's ASH, showing a significant advantage in terms of PFS, 53.6 months compared to 17 months median, and in overall survival, despite most patients crossing over to fixed therapy. So again, suggesting we should use our most effective therapies earlier, but most patients, again, are relapsing in this setting. So we have no direct comparison between venetoclax and BTK inhibition in this group of patients. If you look at the depth of remission, so in the middle, you can see the MRD assessments at the end of treatment. So 130 patients who've got to 2 years, the majority are MRD negative, and this is defined by the risk factors. So the 17p patients did not, there were many in this trial, achieve MRD negativity, and the mutated had more negativity than the unmutated, as did the complex karyotype. And MRD, shown on the bottom, is the best determinant of outcome. So the MRD negative patients in green do better in terms of progression-free and overall survival. And those patients who are MRD positive have about 18 months before they to the end of treatment until the negative ones before they become positive, and about 2 years before the positive ones progress, requiring more therapy. So when we compare fixed duration versus continuous therapy in CLL, there are some advantages and disadvantages. The key advantages for continuous therapy: it's oral, requires limited hospital visits. There's a clear overall survival advantage. There are many trials showing this approach works and is effective in poor risk disease, be it VH mutated, unmutated, sorry, PP3 deleted, or heavily pretreated. The potential disadvantages are the prolonged use of these therapies and the potential for emergence of resistance. From a fixed duration, patients have treatment-free periods, which is good. It's likely to be cost-effective because of the limited duration and less likely to cause resistance. But a single size fits all probably isn't appropriate, and there are a limited number of trials thus far showing advantage. And at the moment, in the COVID era, using this hospital visits, for example, TLS management, is a potential issue. So what about the future? Just in the last 5 minutes, just to talk through where we're moving. So, and the data from ASH, so combinations, novel therapies, and cellular therapies. So the combination of BTK and BCL2, ibrutinib and venetoclax, looks interesting. This is the Captivate study, of which 58% of patients were MRD negative after 15 months of assessment point, as opposed to 42% where it wasn't confirmed. These were treated differently. So the patients who were undetectable were randomized to placebo or ibrutinib, and the ones who were detectable disease either continued the combination or ibrutinib monotherapy. For the patients who are undetectable disease, there's no as yet difference between the ibrutinib and the placebo arm, although the follow-up is short. For the ones who are MRD positive, we see an increasing MRD negativity with another year of treatment, suggesting we need to tailor these therapies to MRD response. But the PFS is very good for all these. This is in frontline, as shown here. So 95% of patients remain progression-free at 30 months. So it looks interesting compared to the previous data I showed you. Similar data from the MD Anderson, just in frontline 80 patients, we're showing that 3/4 of patients are achieving an MRD negative remission with a combination of ibrutinib plus venetoclax in the frontline setting. And again, in the MD Anderson trial, there's an increasing MRD negativity where if you go from 12 to 24 cycles for those patients who are MRD positive, suggesting that we should be tailoring treatment by depth of remission and again, obviously very good progression-free survival across the disease cohorts. So the combination of IV and frontline looks interesting. We showed our Clarity data, Tal Munir from our group, in the relapse setting, showing that with the combination, but tailoring by MRD response and stopping it after patients achieve MRD negativity. What we found was that the patients who respond very quickly, so after 2 months of treatment, as shown here in the purple, had a much better outcome than those who had a slower response, suggesting we might be able to modify therapy based on an early response, as we do in other diseases. Those patients who had a deep remission had a very high level of MRD negativity, shown on the far right. And this is for relapse refractory disease, the progression-free and overall survival of 50 patients treated with this approach. So this has led to the Captivate trial and the MD Anderson data, and our Clarity data has led to the FLAIR study, which has now completed recruitment, going I plus V versus FCR and ibrutinib monotherapy in a frontline setting, with over 1,500 patients now randomized in the study, and we expect results in the next year or two from FLAIR in the UK. The other approach has been triplet, so ibrutinib, venetoclax, venetuzumab, acalabrutinib with the same venin, and zanubrutinib, all reported at ASH in relatively small phase 3 trials, and all showing very high response rates with about 85 to 90% MRD negativity, depending on the tissue, in most of the studies, suggesting that triplets might also be advantageous, although there's no direct comparison. And this has led to the German group doing the triplet combination with ibrutinib, venetoclax, and the venetuzumab in their German 13 trial, which is close to recruitment, and we're expecting results probably towards the end of this year or maybe next year in terms of MRD eradication of the triplet versus a venetoclax-based regime. And finally, the two for patients who are refractory to BTK and BCL2. The reversible non-covalent BTK inhibitors are looking interesting, particularly the LOXO 305. This is just one slide on this from ASH this year. 170 patients with CLL, mostly previously treated with BTK inhibitors, and many with mutations. And this showed responses in most patients, with about 86% of patients having at least a partial response or a partial response, and this is across the board. So this is an interesting new arrival on the CLL treatment scheme. And then finally, CAR T cells, the one that seems that we struggle to get T cells from patients, but the Lysocell was presented at this year's ASH, an update by Tanya Siddiqui, where cells were collected on ibrutinib, and very high response rates are being seen in relapsed disease with MRD negativity rates in the region of 80%, despite prior targeted therapy, and limited but promising PFS at 24 months. So maybe we have options for patients who fail therapy, but unfortunately, in frontline, this is less of the patients. So in summary, the doublet or triplet combinations of BTK with venetoclax with an antibody promise to give limited duration therapy, and the side effects are manageable, and phase 3 trials are now underway, and the salvage therapies are certainly looking promising. Just finally, to show the current treatment algorithm, which changes very frequently in CLL. 90% of patients are early stage and shouldn't be treated. Those patients who do require therapy in the fit, we should look at the good risk patients by their mutated without 17p. The other ones should probably be treated with a BTK inhibitor from the evidence we have in my mind, although Veno is being tested. If they progress, either switch if it's intolerance, or consider Ven-based treatment. For the patients with mutated disease, you could consider FCR, although most patients decide to go down a targeted treatment route. For the unfit, the 17p should certainly be treated with a BTK inhibitor, in my opinion. The ones who aren't 17p or p53 can consider either Veno or a BTK inhibitor and go down the same route. And for the very elderly, I think BTK inhibitors are probably the most appropriate treatment. With certainly effective therapy is the best palliation. So in summary, novel targeted agents are clearly have eclipsed chemotherapy when it were available for all newly diagnosed and relapsed patients with CLL, in my opinion. Initial therapies really have the choice of ibrutinib, acalabrutinib now becoming available on venetoclax or inotuzumab. Therapy for relapsed disease really includes the above, but also PI3 kinase inhibitors in those patients where BTK inhibitors are contraindicated. There's obviously ongoing investigation of novel agents and CAR T cells which show promise, but hopefully as we use the novel agents earlier in the treatment, we'll see less refractory patients. Thanks for your attention.
For the great presentation.